Welcome everyone to the webinar on health systems in situations of fragility. I am Maria Al-Kousa, the coordinator of the Academy at the Global Health Institute. This is the fourth installment of the webinar series on global health and conflict. This webinar series is part of the first initiatives of the GHI Academy, the capacity building arm of the Global Health Institute at the American University of Beirut. The webinar will be delivered by Dr. Sophie Witter, as you can see. Dr. Witter is the Deputy Director of the NIHR Research Unit on Health and Fragility at Queen Margaret University and Research Co-Director for the DFID-funded Rebuild Consortium, which since 2011 has investigated health system reconstruction post-conflict and post-crisis. She is Professor of International Health Financing and Health Systems and has worked in this area for nearly 30 years. A health economist by background, her work in low and middle-income countries has focused on health financing policy, financial access to services, and health worker incentives using mixed methods and theory-based evaluation approaches. Dr. Witter will be delivering her presentation, which will then be followed by a 10 to 15-minute Q&A session. I encourage you all, and please feel free to type in your questions as we move along the presentation. Dr. Witter, the floor is yours.
Thank you very much, and good afternoon, everybody. Thank you for joining us. So I'm very honoured to be part of this GHI series, and my topic is a very broad one. So I'm going to be picking up on some experiences and research that I've been involved in and other colleagues, but by no means exhaustively. So I look forward to a good discussion, and do put your questions for us at the end. So what I'm going to be talking about is just briefly some of the programs which Maria just mentioned, which influence the talk itself, and then to think a little bit about the concept of fragility. So what does it mean? And what does it mean in particular for health systems? And I'm going to be picking up on some of the research and some of the issues and challenges for the different building blocks, but as I said, not exhaustively, focusing a little bit on health financing and human resources and governance, as those are some of the areas that we've been looking at as a research group. I'm then going to discuss resilience. There's been a lot of buzz around resilience recently. Again, what does it mean? And most importantly, how do you encourage it? And then finally, talk a bit about the field of research. And that's also where I'm particularly interested in your insights. So as we go through this talk, it would be great if you could think about, and indeed put any thoughts you have in the chat box, around firstly what you see as a priority question. So what are the areas that we as a community should really be focusing our research on now? And secondly, how we build partnerships and capacity to enlarge this field, and also thinking about getting evidence into practice. So just bear those thoughts in mind as we go through the presentation, and hopefully we can come back to them at the questions. So just by way of general background, as Maria mentioned, the Rebuild Consortium, which is funded through DFID, has been working on health system reconstruction for the last 7 years, and quite a lot of the examples and ideas that you'll see in the presentation come from that work. I'm also going to be drawing on a project which looks at resilience in relation to Palestinian refugees from Syria, which is a very nice collaboration with colleagues at AUB. Some early findings from that project. And also drawing a bit on a consultation which I undertook with a colleague on for the Global Fund on resilient and sustainable systems for health. So lots of acronyms, but that's what RSSH is about, in what they call challenging operating environments, which overlaps to a large extent with the fragile group of countries. And then finally, as Maria said, talking a bit about the work we're doing in this NIHR funded research unit, again collaborating with colleagues at AUB. Okay, so that's some of the background. Let's think a little bit about this concept of fragility. So what does it mean? In fact, there's a massive literature around fragility. There are eons of papers that have been written about it, and multiple definitions produced, including by all of the major organizations which invest in this field. But the happy news is that really they do coalesce around some core areas. one of the three main areas is focusing really on capacity and willingness to provide basic services. So it's around provision of healthcare, in this case, particularly focused on vulnerable groups. And so looking at gaps in that ability. Secondly, around legitimacy, so the degree to which you are an accepted government and indeed have control over different areas of the country. And finally, an aspect which focuses on authority and also control of violence. So this is the dimension that intersects mostly with security. So these can be applied at a state level, but also at a sub-national level. And many of the countries that are fragile and conflict affected can present a kind of mosaic pattern. So we recognize that there are many internal differences often. And also that countries can do well on some of the dimensions, but not the others. So it's not a uniform concept. There are, as I said, these three main axes within it, at least, if not more than three, but at least those core elements. It's also important to emphasize the fact this is a very dynamic definition. So states and regions and sub-regions can move through a lot of changes, can go in and out of different categories. Although having said that, it's interesting that a recent study did analyze 131 countries over a decade and found that during that period, 108 remained within the same categories that they'd started. So it's fluid, but nevertheless, you can get stuck often in some of these poor performing categories for considerable periods of time. It's also interesting and important to notice the intersection with conflict, which is why we commonly use this acronym of fragile and conflict affected together. Because many of the countries that perform worst are those which are affected by conflict or natural disasters and disease outbreaks. And you can move out of those, but often there are many relapses. So countries often go in cycles in and out of conflict. But as well as conflict leading to fragility, the relationship also runs the other way. So fragility can also predict conflict. And we've seen quite a lot of that in the MENA region. So where you have, for example, you might have high capacity, but perhaps low legitimacy can lead to conflict and so you create the cycle. Okay, so that's just some background on the kind of concept, and just to illustrate from one study that you can classify, in this case, countries, but as I said, can be done at different levels, into these different groups. So, for example, there might be some which have a capacity gap but perform adequately on the other two dimensions. In your top left corner, in the top right, you can see ones which are seen as having problems of legitimacy but maybe don't have problems in other aspects. And at the bottom, ones which face security challenges but perform well in other dimensions. And of course then multiple overlapping categories between those, and the ones which are most challenging are clearly the ones in the middle of the Venn diagram, which are affected by problems in all three dimensions. So what does that mean for health systems? Clearly the overall effect is a weakening in respect of most of the health system building blocks. And so this, I've just put an example of one study by Neubrander and colleagues, highlights some dimensions which they observe in health systems in fragile states. And you'll see that, I'm struggling to read my red on my slide here. You'll see that, governance, information systems, human resources, there are many challenges which we'll go into in a little bit more detail. But it's also important to note that it's not all about problems. It also offers the opportunity for innovation and experimentation. So some of these fluidities and gaps can also allow us to observe some very interesting experiments at the local or national level, which we can learn from. So perhaps it's not necessary to spend very long on this slide. Why do we focus on them? On one level, it's fairly self-explanatory, but just to highlight that, of course, the majority of the poor population is now focused in fragile states, so around a third of them. And also that the bulk of deaths, for example, mothers and children, are also happening in these areas, so they have a concentration of need, but also that many of the underlying trends which are causing problems, such as conflicts, have been exacerbating. And on a global scale, it's is seen as something where there's an important global public good in investing in improved health, not least because there are threats to the wider global community around exporting risks. Nevertheless, it's important to highlight that fragile states receive about half of the aid that would be predicted based on their income levels. So in other words, there are also risks which are perceived, explaining underinvestment. And also in relation to research, the area has received a lot less support than you would expect from this high level of need. So let's think a little bit about some of the building blocks. As I said, what are some of the main topics that are being covered and are understood, and also where are the gaps? So just to start on health financing, going back to the start of the rebuild work, we did a literature review looking really at what was known and what was not known on health financing in 2012. And what we observed was that much of the literature focused on the immediate post-conflict period, so much less on following through the kind of trajectory of what happened afterwards, what was the consequence of some of those investments that were made or not made in the post-conflict period. And also that the literature was very focused on the role of donors, and I think that is understandable in relation to the important role that external players play. At the same time, the whole domestic agenda and how health financing is managed domestically is important to study in more detail. So we observed that there was a need to look more at changing mix of financing mechanisms, particularly in relation to equity and access, but also some other topics such as research allocation, regulation, public financial management, and also payment systems and incentives for health workers. So these were all areas that were really important, didn't really seem to be reflected in the literature. And also the need for more longitudinal research, as I said, to understand longer-term implications of choices made. So that was back then. Just to pick up on some of the themes emerging during or since then, one of them, which is of course of great interest, is understanding how health financing can contribute to wider state building and mitigation of political risks. So the literature recognizes that this post-conflict moment presents both risks and opportunities. So some of the risks are around capture of resources by elites, but there are also opportunities really to reach a new settlement. And there is some literature on this, but it remains quite theoretical. And of course, it isn't very easy to capture and measure some of these dimensions. But we think it's very important that health financing is really at the heart of communicating some political and social values. And it has a potential to indicate and foster things such as social solidarity, also inclusion, of course equity, but also reconciliation between different parties who've been in conflict, establishing human rights and participation, and overall providing a kind of confidence in public stewardship. These are all areas where I think it would be really interesting to collaborate on more detailed research. So in relation to external finance, obviously that's a very key topic in these states. Domestic resource mobilization is much more limited on average than for other countries. So around 14% of GDP is raised in tax in the fragile states group, according to an OECD study. That compares with around 20%, which is the kind of targeted level, the desired level. So there will be a continued dependence on external financing, and the assumption is generally that will decrease over time as countries move away from crisis or conflict. Nevertheless, there's not been much study of whether that really happens, and our observation from some of the case studies we've been involved in is that in fact financial dependence can intensify. And that may not be problematic as long as there's appropriate use and stewardship and an actual effective delivery of health services. And perhaps we have to expect a much longer time horizon for moving away from financial dependency. Certainly in the case of countries like Cambodia, we've been looking at about 2 decades to rebuild some of the health system components and to move towards a better coordination through the public sector of policies. So another topic which has received quite a lot of research and is clearly presents a challenge is around user fees. During the humanitarian period, they're quite clear understanding from most agencies that user fees are not an appropriate financing mechanism or resource raising mechanism. But nevertheless, in the post-conflict period, these can be reimposed. And despite the fact that it's clearly a very challenging environment for households to pay through this mechanism, because public finance is not adequate to provide funding to the frontline services, you often get a proliferation of informal and formal fees. So some of our research has been looking at how household financing patterns change. For example, in Uganda and Cambodia, we saw a shift from use of formal private providers to public and informal providers, particularly amongst the poorest. We've also looked at some of the policies that have been introduced to reduce out-of-pocket payments, again in Cambodia, but also in Sierra Leone with the Free Healthcare Initiative, and found that while they have reduced costs, their effectiveness has been limited by a range of financing and also supply side constraints. So just raising some of the challenges of equitable access in these contexts. There's also some interesting examples, not very well or widely documented, around targeted insurance schemes. So for example, there was a health insurance scheme for IDPs in Darfur, which has been written up, but I think again is an area where there's a growing interest in different kinds of financing modalities. And I think a really important role for civil society to try and engage and provide pressure for accountability and equitable financing, something which is supported in many countries by NGOs, but hasn't received as much attention in the academic literature. We've also been doing quite a bit of work on the area of performance-based financing recently, not least because we've seen a proliferation of this mechanism in fragile and conflict-affected countries. And we were really interested to understand why and also how they operate in this context. So with colleagues, we've just recently published a sort of hypothesis-based literature review where we looked at existing schemes, in fact 23 schemes in the end, across fragile and conflict-affected states. And we did indeed find what appears to be a greater concentration. It's a mechanism that's expanded in general, but seems to have particularly expanded in these countries. And often they were early adopters. And indeed, many of them have got a wide range of schemes which have been developed over the years. So the example is just given here from DRC and Burundi, and you can see that these countries have had to develop and manage a kind of a rapid succession of pilots and different schemes. So one of the questions was around why this kind of rapid adoption had happened, and some of our hypotheses around the role of donors, for example, around greater openness to institutional reform and indeed lower levels of trust, were apparently supported by the literature such as it is. Obviously there's room for many more studies. We were also interested in how the policy had been diffused. There are quite interesting patterns of, early pilots through NGOs and then a kind of a rapid diffusion through agencies and individual kind of policy entrepreneurs. But also the use of kind of evidence to promote a narrative of success. So what these suggest is that the conditions of fragility may indeed have favoured the rapid emergence of this model. And we really are highlighting the need for more research looking at how the implementation interacts with the context and what the long-term effects on health system are. And particularly the overall question being, is it circumventing problems in fragile states, or is it actually addressing them in a longer-term way? So building on that work, we've also recently been looking at how performance-based financing has been adapted to humanitarian settings, looking at 3 case studies, and this is an article which will appear shortly, but where we've looked in effect, where we've looked at how the core principles of performance-based financing, which are the ones that you see in the center of this diagram, have been modified in practice in these more challenging contexts, and really what are the contextual drivers of that, as well as the organizational facilitators by the implementation agencies. So this again is an area where I think further innovation will occur, and indeed further research in terms of effects particularly will be relevant. So moving on to some findings relating to the health workforce. So a lot of studies have documented the kind of distortions that occur in the health workforce post-crisis, particularly in terms of gaps in some of the cadres, and also brain drain and a maldistribution as people flee from areas which are insecure. And there's some short-term responses to that around use of foreign staff, which can be immediately effective, but also pose some longer-term risks. There's also quite a lot of evidence around the use of short-term training, some of its strengths and also some of its challenges, and some interesting examples where training of new cadres have been used to develop a very strong orientation, for example, towards primary healthcare. And I think there's some interesting examples of that from Timor-Leste, where we're currently doing further research at the moment. So equally, the introduction of new cadres to deal with shortage areas is something which can be short-term helpful, but also there's a risk in the long term of developing groups who don't meet the health needs of the population, who then have to be phased out. So always, in all of these cases, thinking about when you make short-term decisions, how are you going to manage them long-term, and around some of these issues of path dependency, because reforming something that's been set in place is often very challenging. Equally, we have done some very moving work around how staff have been affected by conflict and how they have managed to be resilient and cope with conflict situations, so documenting some of their personal coping strategies, and really a call for better support for staff, including psychosocial. Health staff, as we know from many regions, are targeted during conflict, often inadequately protected. And once conflicts finish, are often not recognised and rewarded for the commitment that they've shown, those of them who stayed in the area. So bringing out some really important policy messages for the humanitarian and development communities and agencies. We've also tried to look at this issue of windows of opportunity. It's a general topic, but we've studied it particularly in relation to the human resource policy development, looking at whether you can really radically reform in the post-conflict period. And in the countries that we looked at, we didn't find the window to be in that immediate post-conflict stage, partly because of lack of capacity and other challenges around coordination. But found some interesting examples of reforms that happened a little bit later, when their kind of happy configuration of political mandate and external support and also capacity were there. So we recognise, I think, from some of the wider literature, the fact that conflict and crisis can be a very strong propelling factor for reforms, but nevertheless it's clearly not a guarantee that they will take place, and certainly not immediately after. And we've documented also how some of the decisions made post-conflict can have a longer-term implication. For example, contracting out of services, it can be hard then to reverse and take back into public control some of the core service packages, or indeed it can take quite a long period of time to re-establish that service offer. And I think there's some important lessons coming out around how we develop incentive packages for staff to keep them working, particularly working in the more remote areas. And so within Rebuild, we've done some work relating to complex remuneration, looking at the many different funding forms that come to staff and what that means in terms of their behaviour and their accountability. Really, and looking at the lessons for how to manage this very fragmented field. So what we draw, the general conclusions that the wider literature draws around this relates to prioritising hard to reach areas, but also a recognition that often the interventions focus quite heavily on financial incentives and ignore some of the potentially more challenging but also more effective approaches around reinforcing supervision, consultation. Often communication is very poor, staff feel marginalised. So these are things which could be done relatively easily, but are often neglected. Equally around improving working conditions and having policies which are gender sensitive, which recognise the different needs of men and women at different stages in their careers. So in relation to rural retention, really just to emphasise the point about the hard to reach areas, many of the studies find that they're particularly affected by difficult working conditions, and also limited access to families, and generally less attractive working environments. And often a kind of deployment and rotation system which doesn't favour or doesn't support people who make the decision to serve in those areas. And commonly we find that there are incentive packages for rural areas which really are not well funded and not well implemented, and generally ineffectual and receiving limited support. And these areas often face problems of insecurity as well. Having said that, there are cases where living and working in rural areas can be advantageous, particularly where the cost of living has become crazy, as happened during the hyperinflation, for example, in Zimbabwe, in which case living to some extent off the land became an attractive option for some health staff. So what does that mean? What that means is that we need to be better at recognising the achievements and the contribution of people who are working in these circumstances, and really thinking very practically about how do we protect them, how do we provide decent housing and terms and conditions, but also ensuring that they are prioritised for training and promotion, which is something that is commonly not happening at the moment. So I'm going to move on to a few final topics before we come to the research area. So just to highlight, again, there's a literature around managing health markets and the role of different providers, recognising the proliferation of different provider types during the post-conflict, post-crisis, and indeed in many fragile states, and drawing out of those some lessons around how governments can really support and build on the relative strengths of the different sectors. So particularly important is focusing on the role of the frontline providers in the public system, and some mechanisms like performance-based financing can be helpful in that respect in getting resources to those frontline providers. But equally, there's a growing role for the community health workers, obviously have close to community links, but also looking at how to negotiate access through other providers for essential healthcare packages, for example, and ensuring that there really is a level playing field for example, mission and other not-for-profit sectors. the whole question of what goes in the service package, although I've not focused on it today, is a really big topic. And looking really at what are the core services that are provided in that immediate emergency period. I know WHO is doing a lot of work on this at the moment, but how you can build on those later on, and trying to bring in some of the neglected areas. And I think we had a couple of presentations earlier in this series looking at mental health, for example, and non-communicable diseases. Those are also growing burdens of disease which tend to be very neglected. So understanding how you can expand progressively the service package as we move away from crisis towards universal health coverage, and ensuring that those really are offered in the areas where the population is, because obviously all of these periods of crisis tend to involve population movements. It's sometimes assumed to be temporary, but often isn't. So, for example, people moving into slum areas, those have to be then where the services are offered. So ensuring that we meet the needs of the population. There is, of course, also a huge literature around aid effectiveness. I'm touching on it very briefly here, but a lot of emerging consensus around good practices for aid, especially focusing on the need for long-term financial commitments, also the need for flexibility, the importance of building government capacity and avoiding harms. And we know about a lot of potentially diverting strategies like per diems and hiring people away from government services and so on. So a need to avoid those bad practices. The importance of alignment, of course, and also service integration. So there's a big literature around the global health initiatives and the need to manage the risk of vertical programs, and also agile performance management and measurement. So I'm just highlighting here one study that was done by Rebuild in northern Uganda, where we use social network analysis to assess satisfaction with aid relationships at a subnational level. So this is in the north. And just to highlight the three sort of top findings, which I think are intuitively very clear. One is that the ability to negotiate priorities was a key element of satisfaction with aid relationships. Secondly, awareness of expected results, so clarity around performance, if you like. And finally, provision of feedback. And so these are things which it's not only apply, I think, at the organizational level, but also linked to our findings on individual health workers, for example. So again, work that can be extended, but I think interesting methods and interesting findings there. So coming on to the topic of resilience, as I said, this is an area that's received a lot of interest recently. There's been a lot of debate about what it is. Is it a good thing? Is it a way of shifting blame onto local staff and communities to sort of manage in difficult situations? If it is a good thing, how do we foster it? And again, I wanted to highlight a study that was done in northern Nigeria. In fact, it was done in 3 settings, one of which was northern Nigeria by colleagues at Columbia under Alistair Ager. And really that was an interesting method of rather rapidly building models to look at both threats during crisis periods, but also ways of managing them. And so highlighting some of the positive adaptations and positive coping strategies. And some of the early lessons coming out of that, which I think are useful for a programming point of view, focus on, for example, the importance of building stocks so you can cope with shocks. Stocks being not just hardware, but also software, so social capital and so on. But also understanding how to develop devolved capacity, which intuitively also makes sense if you've got rapidly changing and challenging environments, that you've got local level decision-making ability. And finally, also thinking about parallel systems. So where one system is blocked, have you got enough alternative methods for managing your drugs or whatever? So starting to develop some sort of practical lessons. But so this work was then built on by a study that I'm involved in with colleagues from the American University of Beirut, and we will be publishing our first article on it shortly. But here we were trying to understand how UNWRA, so this was looking more to an organizational level, how UNWRA coped with fluctuating populations of Palestinian refugees from Syria, with changing health needs in a kind of conflicted environment. And our findings suggest that UNWRA has been broadly resilient. So where you see shocks, you also see quite quick recovery of services. And we were really interested to understand and work with them on how that was managed. So just picking up some of the findings from Jordan and Lebanon, we found 3 areas which fit more or less with some of the current thinking around absorption of shocks, around adaptation, and also transformation. So these 3 dimensions which are coming out of the literature. And I think I'm being reminded that we have to finish shortly, so I'm not going to go through them in detail. But as I say, we hope to publish this soon, and there are really some very encouraging findings around the strategies that the organization adopted to survive during this period of, as I say, fluctuating demand and conflict in the region. So just to move finally to the question of health systems research, if we look at the trends in studying fragile health systems, and this is a scoping study which is being done for the NIHR Unit for Health and Fragility, you can see on the bottom right that this really is a field that has been growing very rapidly, and you can see a sort of spike in publications in this area around 2015. And if you look at the regions that the studies are focusing on, it's clear that there are a lot of multi-region studies, which I think is encouraging, but also quite a big focus on sub-Saharan Africa. So there was a research priority setting exercise which was published 2 years ago, and that was interesting because it raised, and this was done through the thematic working group on health systems in fragile and conflict affected settings. It raised a number of dimensions which are summarized in this table. And I think when we compare that with the existing literature, you can see that quite a few of these topics have in fact been explored in recent years, although there's definitely some significant gaps. I think it's also important just to raise the issue of capacity, the importance of developing not just institutional but also individual and organizational capacity, and as I highlighted earlier, not just in respect of research skills but also the important areas of getting research into practice, and indeed research management, which often still requires a lot of development. And in this context, we've seen some nice examples of how setting up networks, for example, how establishing repositories, and generally fostering a demand for research can be very effective. And recognizing the need to develop a learning culture, not just within the wider community, but even in academic organizations where sometimes research sharing is not done as effectively as it could be. So I'm going to leave it there. There's some resources which are there for your information, and obviously any questions relating to any of the above, do type it into the chat box. And just to return to that set of questions that I put at the beginning, would be really interested in your thoughts on that or any other topic. Thank you very much. So I'm now looking to see if we've got any questions. Okay. So we've got a colleague highlighting an UNWRA call for research proposals and focusing on evaluation of interventions in health system strengthening in fragile straits. So I think one of our colleagues here is raising the question about research methods. And again, I think others are free to react, but from my perspective, the research methods which are appropriate in post-conflict settings are not in themselves different from any other settings, so ideally very similar, but I think some of the topic areas can be more sensitive. So I think from our experience within Rebuild, there is a need to focus on very good training in kind of sensitive, for example, and empathetic skills. But also we have focused, I think, or tried to develop tools which look at as I say, longer term trajectories, so that be that from a policy analysis point of view, or indeed using methods like life histories, where you can look at individual experiences and decisions and factors feeding into those decisions over a whole lifetime. And that is one way of retrieving historical experience or looking at longer term trends where data sources are potentially a little bit weak. So I think that the range of methods can be quite broad, but we are sometimes forced to innovate in the same way as health systems are forced to innovate. We're sometimes as researchers forced to innovate because of the data gaps or data weaknesses. That can be a good thing. So to my mind, this, for example, this health system modelling that we've been using, looking at refugee care in the UNWRA case, is a very nice example of a participatory, relatively rapid, but still very informative research method, which can tell you about some really important, as I say, not just blockages, but also positive strategies. And we are now trying to add to that with some more quantitative data analysis. That's an element which we're still testing. But even without the quantitative data, or in settings where that might be lacking, there's some really interesting work that can be done qualitatively. So I think there's a huge toolkit out there. To me, it's not methods that's really a challenge now. It's more around energizing and engaging and funding and developing capacity for researchers. But again, I'd be really interested to hear your thoughts on that. So I can see also there's a question around ethical considerations, and I think one of the resources which I put on that final slide was a link to the RINGS consortium, which is a cross-consortium group that we've set up focusing on gender and ethics in health system research. And that link will, I think, take you to some very interesting resources around research ethics and recognizing the need to, as I say, take a more sensitive and context-specific approach. So do give us feedback. If there are particular things that you think are needed which are not there, we'd be really interested to hear about that, and then we can work on that area with colleagues also in Resist and Future Health Systems who are collaborating on RINGS. Yeah, okay, so then I'm seeing a message from Hala around definitions, and I agree. I mean, the definitional area is a bit of a nightmare, and it's a minefield. But while the three dimensions that I highlighted at the beginning are, I think, indeed also political and economic, or at least overlap heavily with the political and economic sphere. in terms of concepts like legitimacy, for example, or authority. These are inherently political concepts. They aren't just related to conflict, although they overlap with and are affected by conflict. And equally, the economic side, I agree with you totally, is very important. I think, also the levels of economic development are very important. I think I did raise that, but it's not built into those fragility notions because, of course, fragility can occur at higher and middle income level country as well, or at the subnational level. So I agree, it's sort of complex, and it's whole books and papers have been written just around these different definitions and terminology. It can be very confusing, but I think, let's try and boil it down to some sort of common elements which make our lives easier, to sort of share understanding and be on the same page. But yes, perhaps I'm oversimplifying. So there are many other dimensions, and as I said, dynamic as well. So right, that's great. So people are sharing some other ethics tools on the chat box. Again, as I said, if there are particular gaps, either substantively in terms of the research area or indeed of specific challenges that you've faced, I think it would be enormously useful to have those, because obviously we are trying to develop these resources and also to share them through communities of practice. So I mentioned about setting up networks, and one of the organizations or networks we're supporting is the thematic working group for fragile health systems in fragile conflict affected areas, and I've put a link to that on the resource page, that's a really good place for sharing experiences, or indeed for sharing research needs or other resources. Yeah, okay, so I'm seeing that Manish has put a question about cross-pollination even, between the thematic working group that I just mentioned and the evidence to action one, which is another health system global one. And the honest answer to that is I'm not sure. I'm not aware of it. Perhaps some colleagues who are online may be able to comment on that. But I think there are networks and there are systems for all of the HSG thematic working groups to interact and share experiences. There are, obviously, they all have common interests. There's an enormous amount of overlap. Ultimately, because a health system is a system, i.e. it's connected, all of the topics, I think, that the groups work on under HSG have to talk to one another to be effective. So I agree it should be happening. I'd be interested to hear from other colleagues who are more involved in both of them, also particularly in the evidence to action one, whether that's happening. And it seems that from what colleagues are typing, that indeed those conversations are occurring. Okay. Yeah, I think the question about key pillars is a really difficult one, because again, all of the pillars are important, and there aren't really any that you can say are not important to assess in a post-conflict situation. Clearly drugs are very important. They are a driver of people coming to health facilities. They are a driver of costs at the household level, I didn't talk much about them today, but they're absolutely central. And similarly, health information, which I didn't go into today because I already had too many slides, as you can tell, is critical for any form of analysis or management or intelligent reaction and problem diagnosis and so on. So I think all of the pillars are really critical. Of course, governance is the kind of glue that links them together. I think it's really hard to prioritize. The linkages are really important, and one of the features of resilience is that ability is an interconnectedness. It's really that there's good information flows between the different parts of the system, between the different actors, indeed between the pillars, that they're not operating as silos, and therefore allowing a kind of rapid responsiveness and kind of course correction. The ability to learn and course correct is probably one of the main indicators of a resilient and responsive health system, in my view anyway. Again, thoughts are very welcome. Okay, so that's helpful. So again, colleagues who are involved in the thematic working group are just highlighting some of these operational linkages. Also with the UHC 2030 group, who are very actively looking and indeed recently commissioned a whole literature review around this area. It's not public, so I haven't shared it in the resources yet. So a really important point there around linking between health security plans and national public health plans. And I think that's something which we've seen develop recently, particularly in places like Sierra Leone, where you have major epidemics. And indeed, this is another area where there's a sort of growing international attention and focus, really looking also at this management of externalities, as I highlighted earlier. So I don't know if there's any final questions. I think we have to wrap up the seminar at, well, it's 3 o'clock my time. But I think that any reactions or comments or thoughts after the seminar are also very welcome to share with the organisers. And indeed to send in any thoughts after the session on what our focus should be as a research community. That would be very welcome. So we'll be sharing the link with the recent literature review that was done for the UHC 2030 group, which in fact we can add on to the slide set before it's shared maybe.
Thank you, everyone. Thank you, Sophie, for this lovely and engaging talk. I see a lot of you have questions. We will be sending the recording and a feedback survey. So any questions or concerns or suggestions that you want to take forward, we would really be happy to address these. And I'd like to encourage you all to tune in for our next webinar, which will be held on May 31st, and it will be on infectious diseases and conflict. So thank you so much, Sophie, again, and thank you all for joining us.
Okay, my pleasure. Thank you very much. I look forward to carrying on work with you all. Bye-bye.